So I titled this Flight of the Navigator, Elevating Maricopa County's Mental Health System. Consider how powerful a supportive person can be by your side as you traverse the challenges of life. We all know the feeling of needing support, and when it's not there, even the simplest of tasks can seem overwhelming. The burden of navigating daily life challenges is an uphill battle for so many people who suffer from chronic illness and who are also economically and socially disadvantaged. Now consider having a great need for specialty healthcare, but lacking the ability to access these services due to either limited health literacy or clinical flows full of kinks and barriers, or both. We have problems on both the user and the delivery side of the health system. Mental health providers, social service agencies, first responders, law enforcement, jail, court system, probation departments, they all provide services for people living with chronic mental illness. But the entire system is fragmented with inefficient coordination that's evidenced by gaps and redundancies. The poorly coordinated care of co-occurring health conditions, combined with the complicated navigation of services, contribute negatively to the burden of treatment and overall cost to society for people living with mental illness. What makes this problem particularly tangled is that people rarely have one singular health problem or issue. The prevalence of co-occurring chronic conditions is steeply growing. 40% of our population, 133 million Americans, live with a chronic illness. And currently, 1 in 5 adults in the United States experiences mental illness each year. People with low income and ethnic populations are less likely to access needed behavioral health services. Further, people with mental illness are more likely to have other serious health conditions. Nearly 30% of Americans have at least 2 chronic conditions and are responsible for 2/3 of healthcare spending. Today, half of the homeless population in Maricopa County are over the age of 50. As many as 1 out of every 3 have co-occurring chronic mental and physical illness, which are direct contributors to the increased homelessness prevalence in this age group. Our current approaches to healthcare treatment rarely take into account patients' capacity to cope with the workload of accessing and maintaining care. This is really a missed opportunity and may impact patient outcomes because patients who have treatment workload that exceeds their capacity to navigate health systems are more prone to non-adherence, leading to worsening outcomes overall. Navigation is the work that individuals must do to form this nexus that connects so many multiple disconnected service providers to create a functioning personal microservice system. Engaging in relationship-based healthcare is a core competency for healthcare workforce of the future. Yet our healthcare workers report feeling ill-prepared and too time-pressured to address the psychosocial needs of people and families. Arizona has more than 700 mental health professional shortage areas, despite the map being covered with all of these providers. It means that the federal government has officially declared there are not enough providers to treat the population. This underprepared, overburdened Arizona healthcare workforce leaves a lingering unmet need, further worsening the mental health crisis in our community. Only 40% of adults with mental illness in Arizona receive any form of treatment. The remaining 60% receive no formal mental health treatment. And according to Mental Health America 2020 rankings, Arizona ranked 36 out of 50 states for providing access to mental health services. The mental health clinical provider shortage problem, coupled with individual challenges surrounding the navigation of a complex and fragmented mental health system, create difficulty for people living with mental illness. We have thousands of mental health service providers in the state and hundreds in the county. The result is a difficult system to navigate and a population ill-equipped to take on the burden of treatment, so they often give up. And honestly, I don't blame them. It's overwhelming, and we in the healthcare industry call these people non-compliant. I really hate that word. Rather, this person is disempowered and exhausted. First responders are exhausted too by this revolving door phenomena and them being the new de facto street mental health care workers. This system, this giving up on our primary care pathways, ultimately leads to the overutilization of crisis care pathways, which were largely ineffective and very costly to society. A project prompted by Phoenix Mayor Gallegos and the ASU Center for Behavioral Health Policy prompted a collaborative team to come together, including my fellow Katie Pine, and we began building and developing a process map of the Maricopa County mental health system. This map is still in progress, and its completion is one of the deliverables of this CUR fellowship. In Access's letter refuting our low national mental health rankings, the robust workforce of the peer support specialist is cited. In the state of Arizona, we have over 1,300 trained peer support specialists and 2,800 credentialed peers serving in the continuum of care and on assertive community treatment or ACT teams across the state. While the work of ACT teams has diverted hundreds of people from the 911 crisis system, this revolving door phenomena is still an urgent and costly problem. An ACT team is designed to provide individualized, flexible services to those living in the community, and each team is composed of diverse health professionals with varied experience, including a psychologist, a nurse, social worker, substance abuse specialist, voc rehab specialist, and a peer specialist. Now, this peer specialist, the peer support workforce is what I want to highlight as a strategy for elevating our mental health system. A peer support specialist is a person with lived experience who has been trained to support those who struggle with mental health, psychological trauma, or substance use. Their personal training of these challenges provide peer support specialists with expertise that professional training can't replicate. The literature is very clear that peer support specialists have a significant role in serving the navigation needs of people experiencing mental illness. The peer support specialist serves as a critical bridge connecting the nodes in our complicated system. While this PSS workforce is widespread and well established statewide, the training curriculum in Arizona is not as robust as national best practice models and may negatively impact outcomes. Additionally, research indicates there are problems with the integration of peer support specialists on ACT teams due to inadequate training, lingering stigma, role conflict. Peer support specialists have been stigmatized as non-professional members, non-licensed members of teams. Their overarching effort, there's an overarching effort right now by advocacy groups to elevate peer support specialists as a profession. The Arizona Peer and Family Coalition, whose mission is to advocate for, connect, promote, and develop leadership by peer members throughout our state, is working towards the development of an elevated title, Peer Support Practitioner. This CUR Project Fellowship aims to amplify the work of Arizona Peer and Family Coalition and the Arizona Complete Health Plan to enhance peer support training curriculum guidelines, to include elements outlined in the 2018 report to Congress, Leading Practices for State Programs to Certify Peer Support Specialists. One of the core questions of this CUR research is to explore the feasibility of enhancing peer support curriculum with the core tenets of health and wellness coaching, and provide a roadmap for the PSS professional to be enhanced, to be elevated, with a meaningful credential from the National Board for Health and Wellness Coaching. You may be wondering, what is health and wellness coaching? Health and wellness coaching principles assist people in making behavioral changes. It's very, very aligned with the role that a PSS already plays. They lead to positive lifestyle improvement. Coaching is a supportive relationship between the coach and person who wants to make the change. Positive supporting connection empowers the person seeking change to draw upon their abilities and potentials so as to achieve lasting lifestyle changes. Coaching is not counseling or therapy. Therefore, a coach is not acting as a therapist, a counselor, or a mentor. Coaching helps a person define what is important and set a plan to accomplish a personally valued goal. My research question I really want to look at is, how does the enhancement of peer support education to include wellness coaching and this training to become a wellness coach, how does this impact health outcomes and crisis service utilization in Maricopa County? This road has been semi-paved by heavy hitters in the VA system. The VA system is one of the largest utilizers of the PSS workforce, and they've also initiated a health and wellness coaching in their system. Additionally, the American Medical Association has recently approved billing codes for health and wellness coaching as of January 2020. And finally, ASU College of Health Solutions recently was endorsed as approved health and wellness training program by the National Board of Health and Wellness Coaching. Finally, the deliverables for this project include developing a curriculum crosswalk between the Access Medical Policy Manual that dictates the curriculum training currently for peer support specialists and crosswalking it with the national best practice standards. Completing the mental health systems process map, that collaborative project between the city and the ASU Center for Applied Behavioral Health Policy. Develop a curriculum outline for peer support specialists that they would provide a pathway for this existing workforce to continue their education to become certified health and wellness coaches, and develop a continuing education learning experience for existing peer support training programs. And so my final thank you and kind of collaborators to the ASU Center for Applied Behavioral Health Policy, partners and colleagues in the College of Health Solutions, Karen Mercado for leadership in advancing health coaching curriculum, and Katie Pine for her work on mapping Maricopa process system map. Also, the Arizona Peer and Family Coalition and Arizona Complete Health would be close partners in this project.
Awesome. Perfect timing, Dawn.
Was it?
Yeah, right on. You started a little late because we went like a minute over and you just totally knocked it out of the park. All right, opening it up for Q&A. There is one in the chat. Michael, did you want to ask her?
I can't see the chat. Hold on.
Yeah. No. He's asking, what is mental illness?
An FAQ style question. What is mental illness? So I guess it's the existence of, we have definitely designated codes of what mental illness can be diagnosed to be. Depression and anxiety, they're top 2 prevalent mental illnesses in America. Is there more? You want to dialogue about that?
I have a question, Dawn, if that's okay.
Sure.
It's Nikita. Hi.
Hey.
I think you did a really great job of presenting factual information with, I'm going to call it storytelling, because that's what my political brain has been trained. So like the emotional side and the facts, it wasn't all facts, and it wasn't all like these poor people who suffer from blah, 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 blah. It was a good mixture of this is what's happening in the world, and here's some facts to support it. That's one. And then my second, that's a statement. And then my question is, where, so you mentioned the VA, is your goal to have an implemented standard in the VA only? So yes or no, and then only in our mental health clinics across Arizona, including our children, mental or behavioral health is actually what they call it, clinics. And so those are my questions. Thank you, Dawn.
Thank you, Nikita. Yeah. Well, part of the problem right now is that it is so fragmented, the training. So Access sets kind of the guideline for curriculum. It's a base kind of skeleton curriculum for the training of peer support specialists. And then there are like 30 different agencies that provide very different training. So it's very, it's not standardized. And so the work of that overarching umbrella organization, the Arizona Peer and Family Support Coalition, is working to create a standardized curriculum, and then also working towards a state level test that would require certification. Kind of like the community health worker model. They just passed legislation a couple years ago or last year for certifying community health workers with a standardized test instead of all these different one-off. And so while the VA system is using peer support specialists, the hope would be that this would be a bigger movement. They're already doing this movement, and I would just work to amplify this work and elevate it, by developing this curriculum that's aligned with health and wellness coaching. And there are some models for including health and wellness coaching. It's called a peer wellness coach. Not in our state yet, but moving in that direction. There's a lot of data to support the efficacious model of health and wellness coaching. Really just kind of looks at the person as a partner, instead of this model of let me tell you what you need to do. Now go forth and do it.
Awesome.
Thank you, Dawn.
Deborah, you want to take the last question? You're on mute.
Unless Christina, do you have something you wanted to say?
No, I'm just excited how well this pairs with what I'm going to talk about. So.
Oh,
I hear what you have to talk about that. One thing I kind of was starting to think about in this presentation was the difference between like a therapist and a coach. And I know you said it's not the same thing, but actually my experience with therapy would suggest that it's similar, right? Or at least some therapy.
Scientific integrity in all cases. So
Yeah.
I'm saying in my particular situation, with my claim, my
Janice,
supervisor was
can you mute yourself?
conducting an inappropriate activity that was
Susie, you
going
should
around
need to
proper
mute him.
scientific vetting.
Oh,
Okay.
Yeah.
But I just, yeah, it just got me thinking about that. And I don't know I guess, and it got me thinking about what the potential advantages of a coach versus a therapist might be. One of them, and I don't know if the answer to this is, but is a coach sort of less expensive because they require somewhat less training?
Thank you. Yeah, thank you so much for that question. I'll answer it pretty quickly here. And one does not negate the need for the other. And so they both have very separate roles. And I think that's part of what's the difficulty in these ACT teams is there's some role conflict and role identity that really needs to be clearly defined. But a therapist can work with a person or patient and develop kind of an overarching plan of care. And you're right, because they have that higher level, that higher scope. They can develop some directions with a patient. And then the coach really gets down into that nitty gritty, that daily, even as much as texting, as much as let's meet at the grocery store. One of your goals was to, develop a healthy meal. What do you think you want? What are your next steps in doing that? How can I support you? And really in those micro levels where it really gets down to the high touch point, high frequency. And that's really expensive to have a person with a bachelor's degree or a licensed professional that is paid $25, $30 an hour to spend that much time and have such a low caseload. So our hope is that a coach can actually have high touch point, less caseload, and have it be better outcomes associated with it.
Hey, Dawn.
The crisis system utilization.
In addition to that, Dawn, I think a benefit would be, unfortunately, seeing a therapist and or a clinician is still highly stigmatized, right? And so people may be more open to speak with someone who's a peer or a coach versus that stigma of I'm not crazy, I don't need that. Does that make sense? And so I think that's also another benefit.
Mm.